Thank you, dear. Let me start by saying a very big thank you to the organizers and my dear friend Suvin Shetty for inviting me here. I don't know really what I'm doing here because I don't belong to the management side. I'm a clinician, an obstetrician and gynecologist, and I practice high-risk pregnancy. But now that I'm here, I might as well bore you guys a little bit on in gynecology, you have one big challenge, and improving care, promise you, can be very expensive. But trust me, a failure to improve it definitely lands up being even more expensive. What different can you do in gynecology and obstetrics that hasn't been done from the good old days of Adam and Eve and will go on till thy kingdom come? Obstetrics is something that has been going on ever since you can talk about it. So what is it that you can make different in today's day and age to help improve the outcome of the patients? How do you actually decrease the medical errors in OBGYN? One would be CMEs. The Medical Council of India has come up with a lot of points for speakers, for delegates, for faculty, etc. William Osler once said, "It is astonishing how little reading a doctor can practice medicine, but it is not astonishing how badly he can do it." So imagine, all of us want to practice medicine, but if you're not up to date with your subject, you can make a mess of things. Everybody has to learn, attend CMEs, get your points in. The hospitals by themselves, the management, have to know that your leading physicians, whether they're gynecologists, obstetricians, or others, have to go in, participate, because every new day brings in more information. You can't fix what you can't measure. But a clinical audit is definitely quality improvement process that seeks to improve patient care and outcomes through systemic review of care against explicit criteria and implementation of change. This comes from the NICE guidelines, which all of us swear by in gynecology. Improving clinical outcomes can only come with best practice protocol evidence-based medicine. So we at the Dr. L.H. Hiranandani Hospital finally follow protocols. It is not about a particular doctor-based practice. It is evidence-based. I have told my residents, because they travel from one unit to the other, it is not Unit 1 protocol, Unit 2 protocol, or Unit 3 protocol. It is evidence-based, which is disease-based for the patient. You must have a safety checklist for every little thing. In my operation theater, no patient will be intubated till the nurse, the operating surgeon, as well as the anesthetist goes through the protocol. You have to recite the entire checklist by rote. How does it actually help? You streamline your processes. When you have a checklist and you have satisfied every criteria, you know you have the right patient on the table, you avoid errors of doing the wrong kind of surgery on the wrong kind of side, etc. Complete documentation is mandatory, and we have a booklet which we came up with for our pathways, so we actually document every single thing. The indication, the contraindication, the variances, all of it. So when you want to audit yourself, when you want to go through your data, it's all there. We at the Dr. L.H. Hiranandani Hospital, for non-complicated cases of cesarean section, indicated cesarean sections, definitely put them up in a pathway. Can I ask everyone over here, though you're all the management, how much is your average length of stay for a cesarean section in the hospital? 3 days? Brilliant. We're trying to come up to less than 72 hours post-operative. For patients who come up with a murat, etc., where you are 1 day earlier, that's exactly what we're trying to do. Bring down their costs by bringing down the average length of stay. The second thing that we've actually kind of documented in this one is our patients are in bed only for 6 hours. So you mobilize them immediately 6 hours post-operative. The second thing is we don't keep our patients dill my mouth post-surgery. As soon as they are in recovery room, you have the dietitian come to them with a bowl of Rex jelly. Promise you, I have no invested interest in jelly, but it's just cooling. It kind of gives their stomach a little bit of rest. And yes, they are nil by mouth for 3 hours pre-surgery. So for them who the incidence of vomiting, the incidence of retching is much lower. We do not have distension of abdomen, and we use single-dose antibiotic in the operation theater as soon as the baby is born. We promote exclusive breastfeeding and have qualified lactation consultants that see the patient within the first 24 hours of birth. The baby is put on the breast in the recovery room, so which is within the first half hour of birth. And post-operatively, within the first 24 hours, you have to have a physiotherapist document the visit. She comes there, she teaches them early mobilization, she teaches exercises and follows them up daily for the next 70 hours that they are there in the operation theater. How did this pathway actually come on? We have Dr. Thomas here, we have Dr. Chatterjee, we have Shashikant Pawar. All of these are part of the training process that we've had, and we came up with this pathway with a lot of brainstorming with the anesthetist sitting with us. How much of fluid do you actually require on a patient post-operative, especially with an obstetric patient? We realized that 3 pints were more than sufficient for these patients. One, you preload them when you take them into the OT because we use a lot of epidural or spinal anesthesia, depending on the indication. And post-operatively, because we start them on liquids immediately, we don't need to pump them with fluids. Even our fluid challenge is documented as a protocol. So for patients whose urine output is less than 30 cc per hour, we give them a challenge, only then a fluid challenge. If they do not respond to that, it's only then when you administer them Lasix injection. We document everything, and it is all materialized in the form of a booklet. All my doctors, juniors, and my contemporaries and the nurses are trained to follow the policies that we have laid down for all the women for the elective cesarean pathway. This has been implemented since the last 3 years, and we've been analyzing our data and found that we are improving on ourselves. The advantages, like I told you, came out as early feeding, early ambulation, a load of patient satisfaction, especially for those who are repeat C-sections, who've had their first C-section done in another center. When they come to us, their satisfaction can really be recorded and is marked. The recovery is as good as that of a vaginal delivery. Don't get me wrong, I'm not promoting cesarean section as a methodology for delivery, but the recovery and the satisfaction for the patient is brilliant. It reduces the financial burden on the family and the hospital as well, because we reduce our average length of stay. It definitely should be promoted at a national level. The other thing that we have is a high-risk pregnancy clinic, of which we have a multidisciplinary team approach. We have a lot of faculties where we all sit together in one consultation at one particular time with the family and the patient, and we discuss the problem. You have complete antenatal, intranatal, and postpartum management of these patients as well as the neonate. For the neonates who go into the intensive care unit, we have the Hope Clinic, which follows up these patients. We have a sample diet chart for every pregnant patient, which is defined. Affluent class definitely suffers from obesity, and our incidence of obesity is very high. Hence, we have low-carb, high-protein diets, which are promoted by our dietitians, and we give these to the patients. Partograms are mandatory. It is a part of the NABH process, and we definitely follow them for all our patients. Not only is it easy to kind of document the progress of labor, but for the residents who are learning, it is a point of, it is a good learning experience, and they help to inform you. I can't be present everywhere. If I'm in the OPD, I have my hands there, but my brain with myself. So that's a part of the nomogram that we use. And Foxy has already come up with reckoners, which are easy-ready reckoners, which should be available in every labor room. You have one for antepartum hemorrhage. You have one for postpartum hemorrhage, where you should have regular training programs and drills for all the residents to be able to treat the postpartum hemorrhage immediately. There is also a reckoner available for recurrent pregnancy loss, and much to people's disbelief, you don't need a torch titer anymore. A lot of patients that come to us for second and third opinion come with torch reports. So it has been documented everywhere that you don't need these tests. Improving clinical outcomes definitely involves simulation programs for emergency care, especially shoulder dystocia and eclampsia. Oxytocin, standard operating procedures used 5 units of oxytocin, 500 ml, 5% dextrose, 16 drops per minute, and increased every 20 to 30 minutes depending upon the uterine activity. To end, what are your solutions? Promote more well-informed diagnosis, support optimal treatment planning, take care of all your clinicians. Very, very important, because adequate staffing leads to a lot of satisfied work from the clinician. Improved outcomes by standard operating procedures, improve outcomes with greater transparency, talk to the patient, communicate to the family, half your problems get taken care of, ensure continuity of care after discharge. We have a home care service where all patients discharged from the hospital are visited 1 week post-discharge for their feedback on their care and a check of their vital parameters and their wounds. Use connected care, which is modern IT, to support better outcomes. Thank you very much for a patient hearing.